Hi, I'm Dr. Tara Chadwick. I am a board certified OBGYN with a specialty in pelvic pain um, and GYN surgeries. Typically, I'll explain a little bit about what endometriosis is as well, and that can kind of give us a better idea about what the symptoms are. What endo is basically is where you have the cells inside the uterus, outside the uterus, in the abdomen. We think it gets there sort of one of three ways, but most likely something called retrograde menstruation. So every month when you have a period, some of the blood flows back through the tubes and sits in the belly. 90% of people clear that away, no problem. For 10% of people, we don't always know why. We think there's an immune component and a genetic component to endometriosis. For those 10% of people, those cells stick to the inside of the abdomen and cause a lot of pain and inflammation. Because of the same cells in the uterus, they respond to hormones. So every month when you go to have a period, those cells get stimulated and you have symptoms. In general, the main symptom that we see is pain, or something that we call dysmenorrhea, which is pain with periods. Um, Sometimes, depending on where the endometriosis sits, you can have other symptoms as well. So we oftentimes will see GI symptoms. So that can be anything like nausea with periods. Sometimes people have vomiting, sometimes diarrhea or constipation, or painful bowel movements with your period. We also sometimes can see urinary symptoms if endometriosis involves the bladder. So people may feel like pain with a full bladder, pain with urination or frequency. And then, sometimes we'll see pain with intercourse as another symptom of endometriosis. Typically, we see that mostly just starting as cyclic pain with a period. But, as that advances, people can start having pain outside of their cycles as well. Yeah, so I think most of it is just that it can be the symptoms can sound like other things. We know that there are other conditions that can cause pain with periods that are not endometriosis. Oftentimes patients will be treated for one thing or the other, and then it ends up being endometriosis as their pain continues. I think part of it is that we can't definitively diagnose it without surgery. So I think it would be much easier if we had another modality that was a little less invasive to be able to diagnose. But I think oftentimes part of it is that many women just assume that those symptoms are normal and that it's normal to have a very painful cycle or it's normal to have some of these symptoms. And, while yes, people can normally have cramping with cycles and that type of thing, it shouldn't be something where it's affecting your life. You shouldn't have to miss school. You shouldn't have to miss work. Those symptoms are not normal. So, if somebody comes to see us for a regular visit and they're telling me that they have pain with periods, we want to dive into it. Is it mild to moderate? Is it something where you take an Advil and you go about your day? Or is it something where you're in bed all day, you're not able to function because that's not normal. So I think a lot of people just assume, this is just part of what having a period's about, and it's not. So part of that is just spreading awareness. And then I think, some providers who are not used to treating endometriosis may miss that or attribute it to something different. And, there was a statistic that said average patients with endometriosis will see like 3 to 5 doctors before they get diagnosed. And oftentimes there can be like a 9-year lag from their symptoms starting to a diagnosis. So, it's something that by the time they usually see a specialist like us, they've usually seen other people in the past. So part of the diagnostic process, it can be a little bit difficult. And so that is the main barrier that we see to people getting access to care for endometriosis. And basically, the reason for that is that it can be hard to diagnose. Endometriosis can look like other things. Endometriosis generally does not show up on imaging. There's no blood test for it. So obviously, if you have somebody who's used to treating endometriosis, once we kind of hear about your symptoms, we can reasonably suspect that somebody has endo. The only way to definitively tell you, yes, you have it, is to go in and surgically do a diagnostic laparoscopy, remove those spots. So that's sometimes what can cause a barrier to diagnosis as well. So once you're diagnosed, we basically have 3 different approaches in terms of treatment. One is observation. So obviously, you don't have to do anything about it. Depends on how much those symptoms bother you. We have some good data that exercise before periods can really help with symptoms. We also have some good data about some low inflammatory diets that some patients find helpful. And we have good data about NSAID medications like Motrin, which can actually block one of the inflammatory hormones that endometriosis stimulates. So those things can be done as an option for treatment. The second option would be medical management. So typically that's something for hormonal control, like some type of birth control option. The goal there is to decrease stimulation of that endometriosis. So we usually want you on something that's sort of low dose estrogen or just progesterone to help decrease stimulation of those implants to make periods a bit less uncomfortable. Um, some patients, medical management works very well, but it's not always the option for everyone. You know, obviously, some people can't take hormonal medications, and sometimes you can start having breakthrough pain on that regimen as well. And then the last option is surgery. So that's typically where we go in laparoscopically. We identify areas of endometriosis and we either excise or burn those areas. Um, and, you know, typically we see a little bit of a better response to pain from surgery, but obviously surgery has more risk associated to it as medication. So oftentimes patients will try medication first and then opt for surgery if that's not something that works well for them. Typically with laparoscopy, that's where we go in with the camera. So typically you'll have an incision sort of at the belly button and one on either hip, sometimes a fourth incision, depending on what we see. Um, and incisions are generally pretty small, about the width of the finger. And what we're doing there is we go with the camera, we fill the abdomen with gas so that we can see well. And then we look very closely at all the surfaces in the pelvis and in the abdomen to identify areas of endometriosis. You know, I think it's always important to make sure that you have a surgeon who is very comfortable doing endometriosis surgery and is comfortable identifying it. And most of us who do this regularly will have done an extra fellowship just to for 2 years of extra training for this type of surgery. Um, and the endometriosis can have a classical look to it where it's described as sort of like a powder burn lesion. So it kind of looks like a dark area that's like either dark brown or sort of like dark reddish. That's pretty classic for endometriosis. But sometimes it can look a little bit different. So having a trained eye who's able to identify it can be helpful. Sometimes they can look almost like little bubbles or what we call vesicles, so like a little fluid filled blister almost. That type of endometriosis can actually release more inflammatory hormones and cause additional more pain. And that is actually more common in adolescents. So we want to make sure that we identify that type of endometriosis. And sometimes it can look like tissue that's kind of white or streaky. That just doesn't look like the tissue that matches it. Oftentimes, we'll use what we call narrowband imaging, which is a filter that shows extra blood supply. And so, what that does is tell us where we see extra vasculature. Sometimes that could be an area that's actually endometriosis. So, that can help us identify it as well surgically. And it's worth mentioning that the one of the reasons it can be difficult to diagnose is that endometriosis stage does not always correlate to symptoms. So there are 4 stages of endometriosis, and that's usually staged surgically. So, you know, it has to do based on how much endometriosis we see, how deep and infiltrating the endometriosis is, what organs it involves, whether or not it involves the ovaries, how much scar tissue you have. So all of those little things come together to give you a stage at the time of surgery. Um, but we know that stage and symptoms do not correlate. So sometimes we'll go in to operate for something different, a fibroid, something else, and we see stage 4 endometriosis. And the patients will say, you know, I actually really never had much pain with periods at all. And then we have patients that are in excruciating pain. We go in and it's just stage 1, a couple little spots of endometriosis. You're able to remove them and the patient's so much better. So, you know, I think that's part of the issue as well is that it's really hard to be able to correlate just symptoms based on stage. So stage 1 endo would be just superficial endometriosis involving, you know, not involving the ovaries or other organs there. Stage 2 would be a little bit more deeper infiltrating endometriosis. Stage 3 would potentially involve the ovaries or more scar tissue. And stage 4 generally would mean that you have significant scar tissue there. Sometimes the bowel and the uterus can actually be stuck together. Sometimes you'll have endometriomas, which are cysts of endometriosis in the ovaries. That's the only thing we can actually detect potentially on imaging is that if you have a cyst full of endometriosis on the ovaries. And, you know, like I said, based on what we see surgically, how much endometriosis, where it's involved, how deep it is, and how much scar tissue you have are kind of the things we take into account.
So, I think in any patient that suspects that they have endometriosis, it's always good to seek out some care. So typically you can start with your primary gynecologist and maybe mention to them like, hey, I've looked into some of these symptoms. Could this be something that is affecting me? There's also lots of endometriosis experts now, especially as we're being trained. And like I said, our training has gotten much better over the last 10 years or so. So you can always look for endometriosis specialists in your area. Here in Baltimore, we have a group that's just dedicated to pelvic pain and endometriosis, but there are centers there. And sometimes your primary gynecologist will know where to send you. So they usually will have like a referral base to a specialist. And depending on where you live, depends on the access, obviously. Most major metropolitan centers will have lots of physicians who do what we do. And you would be looking for like a minimally invasive gynecologist or a pelvic pain center. But I would say if you think you have endometriosis, definitely seeking out the care of your physician and then seeing if you can see a specialist is always helpful. And then if you know you have endometriosis, we know endometriosis, unfortunately, is a condition that can recur. So we see recurrence rates, sometimes anywhere from like 20 to 40%. Recurrence is usually 2 to 5 years or so after surgery. So we know it's something that people suffer with for a long time. So our goal is always to make sure that we can manage your symptoms. And obviously, we want to do as few surgeries as possible. So in terms of endometriosis, I think the more that we treat endo, the better we're getting surgically. And I think we've made so many strides surgically with what we're able to do in terms of removing endometriosis. We don't have anything that's FDA approved yet or that has gone through rigorous testing, but there are some things in the work that hopefully would be able to identify patients sooner. And that would be obviously a huge diagnostic tool. And it's really a void there. I think with a lot of the assisted reproduction as well, because we do know endometriosis can affect fertility. So with better access to things like fertility treatments, that's really helped a lot of our endometriosis patients as well. And we think there's maybe 2 different mechanisms to why endometriosis causes issues with fertility. And not everyone with endo has infertility. I think that we usually say about 30% of people with infertility have endometriosis. And we think that part of that is that there's just scar tissue. We know endometriosis can cause lots of scar tissue. Sometimes that affects the fallopian tubes. And if the tubes are scarred together, then egg and sperm can't meet through the ovulatory process. Doesn't mean you can't become pregnant, just means that you would likely need help. Then the other mechanism we think is just inflammation, and we're not really sure why. This was an area that we need a lot of research for as well. We think that it has to do with inflammation because some patients, even with just an easy stage 4 endometriosis, have issues becoming pregnant. And we know that after surgical intervention, pregnancy rates increase within the first 6 months after surgery. So we know that can be helpful to treat it, even if they don't have, a whole lot of scar tissue and a whole lot of endometriosis. So I think, it's just been great to have more awareness about endometriosis. And I think we're getting much better about spreading awareness, not only with patients, but within the medical community itself. So, we're starting to see more patients sent to us for possible endometriosis from GI specialists, from primary care. I think it's just something that's on the radar a bit more, which is great, and the more we can do to spread awareness, the better. I think the goal there is really to make sure that this population feels heard, because I think that's one thing that we see a lot. I've been telling somebody for years that my periods are bad, and I feel like nobody's listening. So our goal is to make people feel that we're listening and that we're here and that we can help.